In this lesson, we will review some of the special considerations for mechanically ventilated patients in the acute care setting and the respiratory therapist's role in rehabilitation. Rehabilitation provided to patients undergoing mechanical ventilation may decrease length of stay, ICU-acquired delirium, and improve overall functional outcomes. The goal of mechanical ventilation is, of course, to return the patient to spontaneous breathing, but complications from the mechanical ventilation itself or medications may slow this process. Weaning criteria consists of resolution of the initial event leading to acute respiratory failure, a febrile, improving or stable chest X-ray, controlled respiratory secretions, and respiratory mechanics with certain parameters. Methods of weaning include IMV rate decrease, spontaneous breathing trials, and pressure support. Other interventions during this process include airway clearance, means of effective communication, and optimizing pulmonary function. Breathing strategies, communication with other healthcare professionals, and preoperative education are also strategies to help prevent or improve pulmonary complications. Although not in the direct scope of care of the respiratory therapist, exercise in the form of both endurance and strength training should begin in the acute care setting to maximize independence and efficiency when the patient is performing ADLs. Critical illness neuromyopathy is the most common peripheral neuromuscular disorder seen in the ICU and often presents as profound extremity and respiratory muscle weakness. Neuromuscular strength can also result from systemic inflammation, hyperglycemia, axonal nerve degeneration, muscle myosin loss, and muscle necrosis. Indications for mobilization and exercise are alveolar hypoventilation, pulmonary consolidation, pulmonary infiltrates, alveolar or bronchial inflammation, pleural effusions, acute lung injury, and pulmonary edema and systemic effects of immobilization such as orthostatic hypotension, increased thrombosis risk, increased decubitus ulcer risk, emotional and behavioral disturbances, and hypercalcemia and osteoporosis. Contraindication for advancing functional mobility through exercise include untreated deep vein thrombosis, unstable vitals, patient unable to follow commands, high ventilatory support, PEEP or CPAP greater than 10 centimeters of water, or other orthopedic, vascular, or neurologic injury that requires alternate bed activities. A precaution is PEEP or CPAP greater than 5 centimeters of water, or PIP greater than 50 centimeters of water, or minute ventilation greater than 15 liters per minute. Exercise should consist of intensity and monitored for shortness of breath and angina, duration, the amount of time the patient can tolerate activity, and frequency, the number of short intervals of exercise followed by rest. Patients should be monitored throughout for heart rate, blood pressure, respiratory rate, and oxygen saturation. The type of exercise may consist of moving in the bed, transfers, standing, walking, stairs, biking, upper body ergometer, or treadmill. Any abnormal response to exercise, such as heart rate more than 20 to 30 beats per minute above resting heart rate, or increased blood pressure 20 to 30 millimeters of mercury above resting, decreased oxygen saturation below 88 to 90%, ECG changes, chest pain, or other signs of exercise intolerance should be noted and exercise should be discontinued. Education of the patient and caregiver is essential for patient-caregiver well-being and compliance to medical regimen. It has been shown to decrease length of stay, patient anxiety, increase quality of life, increase adherence with medical advice, and increase patient participation as an active member of the healthcare team. It must be geared to the patient's needs and learning style. Learning styles may include visual, auditory, or kinesthetic, or a combination of each. The needs of the patient include the domains of perception, which is the ability to receive input and comprehend material presented, cognition, which is the ability to comprehend and remember information. Deficits in this area may require that the patient be given written instructions as a backup to verbal information, or is still unable to comprehend, the caregiver should be instructed. Motor domain, which if deficient may require coaching with intrinsic and extrinsic feedback. Affective domain, which is the patient or caregiver's attitudes, belief system, and motivation levels. If information given is in conflict with beliefs or cultural or religious beliefs, it will be a detriment to learning. And lastly, environmental domain may affect learning if the environment is noisy or if the patient is in an uncomfortable or painful situation. Factors that lead to noncompliance with any program, rehabilitation or otherwise, are number 1, barriers that patients perceive such as lack of time, fatigue, pain, lack of motivation, or difficulty fitting exercise into their daily routine. 2, lack of positive feedback. And 3, perceived helplessness. A family member may be recruited to help eliminate these barriers to adherence, and patients should provide feedback as to the effectiveness of any education program.